So, welcome to Quality Improvement and Health Information Technology. There is a lot of reading in this lecture. I apologize. A lot of slides, but you can pick and choose the ones you need to print. The case studies are the ones that I would really encourage you to print out because those case reviews or case studies are what you're going to use for your discussion. And you could print just those 6 pages, 6 to 10 pages of this, and the rest you could probably read on your computer if necessary. So, learning objectives for this course, we're going to define what quality means in healthcare and test question, ding, 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 ding. Quality, the type of care that everyone should receive. It's the whole basis behind any objective from the Institutes of Medicine is that there is quality care and everybody deserves quality in healthcare. We're going to examine critical relationships of healthcare and that relationship between healthcare and IT, explore the concepts of improving the quality of health IT and the importance of communication. So, quality is the degree to which health services for individuals and populations increase the likelihood of desired outcomes. Consistent with current professional knowledge. So, best practices. We the Institutes of Medicine are looking at the best practice, standardizing that care so everyone gets the same type of care and the same quality of care. And it's how you have access to that care. It's that that care standardized so that the outcome should be predictable. We want healthcare to be predictable and repeatable, understanding that there's human factors and everyone is a unique individual, but that the basic principles are followed so that everyone receives the same type of care with the same expected outcomes. So when we relate that concept of healthcare, we want to have the right processes, the structures, which are the right things that are in place and the process for doing those things right so that those outcomes can happen, the right and expected outcomes are happening. The six aims of the Institutes of Medicine should be safe care, effective care, patient-centered care, timely care, efficient care, and equitable. And your case reviews are going to reflect um, these 6 items, and each one of those case reviews addresses one of them, which you'll be using in your discussion forum. So think about safe care. Um, People should be safe from harm, do no harm, right? Effective care, so that the result is that you would want to give the right antibiotic for the right type of um, disease process so that it can be effective. You want it to be patient-centered, involve the patient. The patient should be at the center of everything that we do. It needs to be timely. Doesn't matter how effective the care is if you give the right antibiotic, if you don't give it in a timely fashion. So it used to be we have to give somebody that was diagnosed with pneumonia, we had to give them a certain antibiotic within an hour of their admission in order for it to be timely, so therefore it would be as effective as possible. We want it to be efficient. It shouldn't take a long time. We have to respect our healthcare workers. We have to respect the time of the patients. So the care needs to be efficient and it needs to be equitable, has to be cost effective. We need to give these patients good, quality, safe, effective, patient-centered, timely, efficient care, but in an equitable means. It has to be cost effective. The Institutes for Healthcare Improvement came up with this little diagram to talk about the triple aim and how we want to do the best care for the whole population at the lowest cost and how that all overlaps. And so when we're talking about it, not any one of these can be all by itself, but it has to overlap in order for it to be good quality care for the patient. So how are we doing that with health information technology? So if you recall from the earlier lecture, it's the use of computers and technology to communicate, to transform health information, to improve processes to give this safe, quality, effective, timely care. And it allows us this comprehensive management um, as well as a secure exchange of that information across healthcare settings. We need to improve the quality care, and we have the potential to do that. We have the potential to prevent medical errors. You can kind of read this slide yourself, and all of that, though, is based on how the systems are designed. And that's really the takeaway from this course I want you all to understand is all systems have the capability, but they can be designed poorly. Remember the Institutes of Medicine, 98,000 deaths because good people were working in a bad system. Meaningful use was one of the driving causes from the American Reinvestment Recovery Act, or ARA, if you've heard that term, from 2009. That's a very important test question. The American Reinvestment and Recovery Act of 2009. The the meaningful use component of that was trying to drive the adoption in facilities. If we could give them an incentive in order to use electronic medical records so we could have this exchange of information across different organizations and across populations. The High Tech Act established the programs under CMS and the Office of the National Coordinator in order to accomplish that charge. So those are the two components. The act was the law put into place that says we need to do this and this is how we're going to do it. High Tech is the organization that established the programs and manages that uh, act that was put into place. So the goals of meaningful use look very suspicious to the Institutes of Medicine for the improvement of the quality, safety, efficacy, efficiency, patient centeredness. You can see that engage patients and families. That's patient centeredness. Improve the population of health and reduce disparities. That's equitable efficiency, timeliness, ensure privacy and protections. So all of those were the goals of meaningful use. So lots of organizations had electronic medical records or some form of electronic systems, lab systems, if you recall. Patient management or accounting systems have been around since the 70s, but we needed to be able to use them meaningfully. And by that, um, we're not talking about somebody just being able to click some boxes and collect some information. What are you going to do with that information? How are you going to make it meaningful and exchange it across organizations? What does meaningful mean? So meaningful, um, it, it has to be useful. You have to be able to use that data for something. Remember when we talk about data just being um, information just being a number, 92. What does 92 mean? Is it a temperature? Is it a heart rate? Is it um, a diastolic blood pressure? 92 doesn't mean anything until you give it a quantifying description or a title. Um, to make it data and then transform that into knowledge. You have 3 or 4 temperatures that are increasing. Now it becomes knowledge and data that you're saying, okay, with the patient's got a temperature that's increasing, what are we going to do about it? And you can start making a plan to care for that patient and reduce the temperature or make an intervention. So that's what was happening um, in 2009, 2008, 2007, we had places that had electronic systems, but it wasn't really being used meaningfully and it wasn't being used in a way that could uh, go across different systems. But you have to have teamwork. So health information technology, we like those places that had electronic systems, they weren't being very useful. Um, and even some of them could hinder it. Remember the 98,000 deaths because they were built poorly. So it takes communication and teamwork in order to make these successful. Some unintended consequences of health information technology were lots of workarounds. So what is a workaround? An alternative process. that workers are doing. So whether it's nurses taking verbal orders and and then trying to transcribe them into an electronic system instead of the doctor using them themselves. Now, why would that happen? Well, physicians have too many clicks. They think they're too busy. There's not good adoption of the system. Maybe the system doesn't make sense. It was designed by a technical person with no clinical background, and so it doesn't meet the workflow needs of a physician. So the physician isn't going to use it. Their workaround is to tell the nurse what to do, and the nurse will make it happen because somebody has to make it work. Somebody has to put that information in. So, um, another example of a workaround, a barcode medication workaround. When I was at a conference one time, we heard a story of a nurse who was convicted of negligent homicide. And this happened because in barcode medication administration, and you can see it in this picture, there's usually an electronic component that allows you to scan the patient's identification band on their wrist, and then that communicates to a locked medication machine, which will dispense the medication for that patient or allow you to select potentially on a computer screen. It may show you all the medications for that patient, and then you select the right medication that you want. Part of that workflow, once the medication is available to you, consists of scanning the barcode on the actual medication and then scanning the armrest again. So how this works is, let's say your patient had aspirin due at 8 o'clock and maybe an antibiotic due at 4 p.m. So you would click on your patient on the computer, you would scan their armband, and two medications would show up, the aspirin and the antibiotic. It's 8 o'clock in the morning, so you want to pick the aspirin. If you accidentally clicked on the antibiotic, it may or may not dispense it, but if it did dispense the antibiotic, you would take, and once you scan the barcode on the antibiotic and then scan the barcode on the bracelet, the computer would give you some kind of warning that would let you know that medication isn't due right now. Now, that doesn't mean you can't give it in the sense that there's usually overrides. These safety mechanisms are put into place to help providers and clinicians, not meant to hinder them. We can't make those decisions for people, so maybe the doctor changed his mind and it hasn't been put in the system yet. Maybe it really is safe to give that antibiotic at 8 a.m. instead of 4 p.m. But the point is, there's mechanisms in place when you scan the barcode of the med and scan the barcode of the patient ID band, it would let you know that it may not be appropriate to give that med at this time. So this particular nurse was taking labels, since she couldn't take the patients with her. She would take the labels that are oftentimes associated with the patient for specimen collection, or they might be to label documents. Sometimes there are extra labels with barcodes on them that are part of some place where they do store some form of paper. We aren't 100% paperless just yet. Um, and so she would take these labels, or she would print them out, take them to the medication room that was at the far end of the hall. She'd scan all the labels. So let's say she had 6 patients, scan 6 labels. Medications would come up. She'd pick the meds she needed. She'd take them to the patient's rooms and give out the medications. And she ended up giving the wrong patient the wrong medication, and they died. The nurse was held liable because the organization was able to prove that they had systems in place. They had policies and procedures. They had a process of barcode scanning the patient, the medication, the patient, the medication type of scanning. And she found a workaround, and therefore she made the choice. She was negligible because she made the choice to work around the safety measures put in place in order to prevent such harm. CPOE workarounds, we were kind of just talking about that. You can see in this slide, it's very, very busy and some of it's not real clear, but 10 clicks. Several screens. Think about the last time you were shopping on a website or looking for something on a website. Maybe it had a lot of extra advertisements. You had to keep closing windows in order to see what you needed to see. Or maybe it put you through several screens and steps. By the time you get to the fourth or fifth screen, you almost don't want to order whatever it is you're ordering online, or you don't want to be on that website anymore. Providers will feel the same way when they're in trying to take care of their patients. CPOE, you'll hear that term a lot. You may hear it as computerized physician order entry, or you may hear it as um, computerized provider order entry. And either one of those are correct. However, I would encourage you to use the word provider, not physician. There are a lot of what we would refer to as mid-levels. So you might have a nurse practitioner, a medical assistant, a physician's assistant, and they may have the same securities and the same privileges to place certain orders or do certain in a program, and therefore but they may not be physicians. So workflow barriers. Um, the In 2005, the Washington Post reported Cedars-Sinai pulled a $34 million system because it had so many issues, safety issues, misspellings. The system was just not designed well. Um, so these are things you have to be cognizant of. I work for an electronic medical records vendor. We need to make sure that it meets the needs of the organization we're placing it in. There are some standardizations that can be done, but there are also some regional and organizational specific workflows that need to be considered when you're designing these systems. This is an example of the case reviews. So we've got safety, we've got effectiveness, um, we've got patient-centeredness, timeliness, efficiency, and equity. These are the case reviews that you will need to review to use for your discussion forum. Patient-centeredness, we'll talk a little bit about. Patient-centeredness is really putting the patient at the center of everything. They should be very involved in their care. Their family should be involved in their care. And they need to um, have tools to help be part of their care. So we'll talk about patient portals, how that information needs to be secure, where they access it, what information is accessible. Disease management is ways we can help them manage chronic disease like diabetes, things that may not be curable, but we need a patient portal or a way to communicate with the patients, particularly maybe in rural areas or in urban settings when we have patients that may be shut in high rises and can't get to the doctor every week due to transportation or just physical limitations. So how can we engage with them in an electronic environment so we can collect data on them? Maybe it's their blood sugars if they're diabetic that they take every day. They can upload them from the glucometer so that the doctor can manage them and see what those blood sugars are, even though the patient isn't physically in their office in front of them. Maybe it's they're on blood pressure medicine, so you want to be able to record and collect and view their blood pressures that are taken daily. That's all part of disease management. So we've talked about patients that suffer from medication errors, the deaths from the Institutes of Medicine that they brought up, hospital-acquired infections. That's what HAI is. So you go in for surgery and you end up dying of sepsis. Not related to the surgery, the appendix. It's not the appendix that got infected and was the result of your death. You had your appendix removed. It was a subsequent infection that you got as a result of having been cut open and having people in your body. Um, this is all adding up to $50 billion. So when we talk about the cost of healthcare, how can we improve patient safety to reduce deaths, reduce mortality, reduce errors, and reduce cost? So make it equitable, right? You need to understand the science of safety. There is an actual science. We've got these 5 things that we need to um, realize. And the first thing we need to remember is that we're human. There will be errors. We aren't going to prevent them all. So if we assume some things are going to go wrong, perhaps we can get ahead of them or put some practices in place and be proactive rather than reactive, um, to mitigate some of those errors that are likely to happen. Realize every system is perfectly designed to achieve the results it gets. Now, what does that mean? It's perfectly designed if it's flawed, because computers are only as smart as the people programming them. Garbage in, garbage out. So if you don't ask the right question on a form for a nurse to answer, they're going to give you the answer that's being asked of them. If you ask somebody what the patient's temperature is and you don't designate whether it's Celsius or Fahrenheit you're asking for, one nurse might give you Fahrenheit and one nurse might put it in Celsius. Two very different pieces of information that will calculate very differently when you're doing a data analysis or mathematics, or it's trying to give you an alert that's based on a particular range of numbers. So it's perfectly designed. That means our job in health information technology is to perfectly design it. Uh, Understand those principles of safe design, how we can use checklists, standardizations. We're talking about healthcare across a nation, healthcare across the world. And if you've got a virus, a cold virus in England, you've got a cold virus in America, we would treat those viruses the same or similarly. Um, and how we can apply these principles, technical and teamwork. So there's only so much we can program, and the rest of it still has to be teamwork communication. You still have to be able to bring it to somebody's attention if something isn't working right. Um, I had one of the students email me that the the notes weren't available. I'm not going to know those notes aren't available if somebody doesn't tell me, doesn't let me know. I can only test so much. I can only try to do so many things. I would appreciate that nobody's afraid to tell me that. We have to be able to talk to each other and work together. And diverse teams. You can't, we're going to talk about care coordination. We're talking about nurses, physicians, therapists, respiratory therapists, physical therapists. We're talking about the lab technicians who are processing specimens or potentially drawing the blood. If we don't talk to each other, we aren't going to be able to use everyone's input, and everyone has a little bit different perspective on their expertise on taking care of these patients. This little Swiss cheese analysis, basically what it's saying is that in a system there were multiple places, multiple holes in the system. If any one person had spoke up, if any one of these holes could have been plugged, perhaps the issue wouldn't have happened. But because there were so uh, many holes and nobody found the one hole, nobody knew where to start. We talk about some aviation issues. A lot of communication came out of some aviation studies where it used to be assumed the pilot knew what they were doing, and we found out they were ignoring the co-pilot. So if the co-pilot brought up an issue, the pilot was like, I'm flying the plane, I'm the one in charge. Does that sound familiar between physicians and nurses? Physicians are saying, I'm the doctor, I went to school for 10 years, I know all the answers. So um, by being able to use some standardized communication tools and um, respecting each other's opinions, we've been able to open those lines of communication and prevent a lot of errors. So standardizing, we can eliminate some steps if we do things always the same way. Um, we have to be able to do after action reviews when something does go wrong and understand how it happened, um, so that we can put some preventative measures into place. And then we need to reevaluate it and see if those worked. There's two approaches to errors. There's the person approach, which is very blaming. So the pharmacist couldn't read the doctor's handwriting, so it's the doctor's fault. The nurse took a verbal order and transcribed it into the computer system, so it's the nurse's fault for taking the verbal order. Or it's the system's fault for not being able to catch the error, the details of what the nurse was trying to put in and alert them they were putting it in wrong. A systems approach takes a bigger picture and says, um, other things, there's human factors involved, but there's multiple failures. There's Swiss cheese issues going on, and it's not just one person, one um, at fault, but multiple things. And how can we use those countermeasures um, to understand what went wrong and make it better? Here's some human factors. We're going to talk about ergonomics, but we've got physical, cognitive, and organizational factors that can lead to errors. And um, ergonomics with physical are going to be able, just think about, you've heard of ergonomics, people think about the way their desk and their chair work together. Um, Cognitive is the systems design and how you think, your normal thought process and workflow. How does a physician or nurse think um, when they're doing a head to toe assessment, right? They start at the head and go to the toes. So you wouldn't want the toes at the top of the page. You'd want the head at the top of the page on your computer screen. Organizational has to do with almost an HR, human resources perspective, having people from a management, like think of shift work. It's not safe to work somebody 2 days on day shift and then they get off work at 7 o'clock at night, and bring them in at 7 o'clock the night next night and work them till 7 o'clock in the morning. You need to have a break between the shifts when you're trying to balance your own circadian rhythms and your own biological clock. Um, a lot of nurses will work 6 days on because it gives them 9 days off. And you'd think, ooh, 9 days, that's like a vacation. But when you work 6 12-hour shifts, and a lot of times those end up being 14 and 16 hours by the time you actually drive back and forth to work, or you're allowed to go home after your work is actually done and all the documentation is caught up, you really are taking half of that time just to recover and get back into the swing of things. You can't just, it's not like 9 days off, especially if you're on night shift for 6 days. So organizations need to take that responsibility to help people have normal schedules, take time off when they need time off, encourage the use of vacation time. So physical is the physicality, how things, how you can reach things, how you sit, where computer screens are located. Cognitive is the system itself and how you use it, and workflow and processes that follow the normal way of thinking, and the organization responsible for helping establish uh, boundaries and guidelines as it relates to work hours and um, schedules. So here's an example of ergonomics and workflow. This nurse probably can't see that screen very well. She may hit the wrong button. One, she's got gloves on. They don't look like they fit very well. She's reaching up, she's looking up. It's not her fault that she's short. It's the fault of the machine for being too high. So what can we do as health information technology folks when we're putting these um, rooms together, and when we're shopping for, helping to shop for equipment, that we design it in such a way it can meet the needs of everybody that's going to use it. A poorly designed system, we've sort of been talking about that, but it doesn't match the needs of the human being or task, and doesn't take into account human limitations. Um, My brother also works for an electronic medical records vendor, and he had a programmer that was so excited that he had programmed this one particular thing, and my brother, who's a nurse, used it, and he's like, there's 14 clicks. It's not going to work. And the programmer was really upset. And my brother said, this is not usable unless you can get it down to 3 clicks. And they went back and forth. It eventually got it down to 3 clicks, but it was poorly designed. It was human limitations because of all the different didn't meet the workflow, too many clicks. It wasn't going to be adopted by the people who were using it. You'll hear terms like active and latent error. Active error is somebody actively doing something. The pilot drove the plane into the ground. The nurse um, actively did not scan the barcode. They chose not to do that. A latent error is something that's previously undiscovered. So the plane had a malfunction and the pilot couldn't keep the plane in the air. Not that they forced it into the ground. They couldn't keep it in the air because there was a malfunction. The nurse barcode scanned the patient, but something in the system didn't warn her. The alert was broken. So they didn't, that's the difference between the active and the latent error, something that's found after the fact that was wrong. 2003, the Institutes of Medicine issued a report to prioritize the transformation of healthcare so that it is quality. And part of that is care coordination, establishing and supporting a continuous healing relationship. So this care coordination, as we go through it, you're going to talk about, again, these chronic conditions like diabetes and heart failure, and how does everybody know what we're doing for this patient to take care of them? So um, if you are the physician that prescribed a medication, let's say you're an oncologist dealing with cancer, and you prescribe a medication, the patient's primary care physician, not the specialist, the primary care should know what medication is being prescribed. The heart doctor should know what medication the oncologist prescribed in case there's interactions between the two types of medications that are being given by the two different specialists trying to care for this patient. Physical therapists, respiratory therapists, case managers, they all need to be able to see this whole spectrum, continuum of care of the patient so they can all make informed decisions about how to help manage this patient's care. Transitions of care is part of that coordination. So um, when one of the meaningful use things that have come to light was called Ops 19, which had to do with being able to give this transition of care record from one place of care to another or one provider to another. And that's provider to provider, so within a facility. So if you're the emergency room physician or you're the surgeon, when that care is transferred to the hospitalist, who's the physician taking care of the patient when they're in the inpatient setting in ICU, you have to be able to have that transition of care and um, care coordination provider to provider. Care area to care area, from the emergency department to the ICU, or from the surgery or OR to the ICU. Facility. This is when you have a patient that might be, let's say you have a trauma patient that needs to go from St. Patrick's Hospital to Harborview in Seattle, or maybe it's going to a nursing home, so from the hospital to a nursing home. Maybe it's from the nursing home to the hospital. So you have to have facility transfer information. Um, Admission from a facility and from home, it has to go both ways. So you may all be familiar with, Community Medical Center has an electronic medical record, and St. Pat's has a different electronic medical record. And sometimes the physicians, primary care physicians, have a different medical record or electronic system they're using. So it has to go all the way around. Not only are the facilities having to be able to communicate with the physicians, but the primary care physicians need to be able to communicate med lists and treatment plans to the inpatient setting so they're all on the same page. I just talked about this a little bit, and there's just a diagram to kind of reiterate. On average, 40 to 70% of all inpatients are going to be transferred somewhere. Now, I would I would guess probably closer to 90% if you want to count transferring, like let's say they go and get an x-ray. So if you come into the ER, you may not be admitted, or you may not to the ICU, or you may not need to go to surgery, but um, you're likely going to potentially go over to the radiology department. Um, so you're still going to get that communication or be transferred maybe to a different location and then back again. Hospital discharges. This one was very interesting. I had someone um, describe it as if you went and had your car taken to a garage for a tune-up, let's say, you would get a list. When you went to pick your car up and pay for it, they would say they put 5 pounds of air in all four tires, they put 6 quarts of oil in, they changed your windshield wiper blades, they checked your fluids. So they give you this check off list of all the things they checked or all the things they replaced or did for your car. When you go to the emergency department, they would give you discharge instructions, but you never really knew sometimes what they did for you. Now, if you're really sick, um, I'm sure at some point during the care they would tell you, we're giving you an IV for fluids, or we're going to draw blood and do some lab tests to look for infection. But it wasn't the details, and they didn't give you this check sheet at the end. And it's been discussed that that needs to change. If you leave the emergency department, they should say that what they did for you, what medications they gave you, what lab tests you had, what x-rays you had, or other diagnostics, who the physicians were that may have talked to you in addition to the ER physician, maybe a specialist, and also what's still outstanding. Maybe not all the lab results were back, like a culture takes 5 days, so maybe not all the results are back, and what your next steps are. But it should give you a list of all those things. This information needs to be timely and accurate and relevant. Um, just like any other handoff. And when we talk about SBAR, we're talking about situation, background, um, actions, and recommendations. So it's a communication tool that's short and to the point. But just like this discharge, it should say the patient came in complaining of ear pain. Um, the background was they'd been sick for 3 days with headaches and sinus condition. The action was we gave them we tested them for strep, looked in their ears, saw an ear infection, gave them an antibiotic, and the recommendation is they're going to follow up with their primary care provider in 6 to 10 days, particularly if they're still having pain. So situation, background, actions, and recommendations. Again, the coordination of tasks, I can let you read this, coordination of care, that it's teamwork, um, it requires communication. One of the interesting things on this slide, if you read through what's in there is, and this I've seen this in the ER when I used to be an ER nurse, you would say, the physician would say, I need a stat antibiotic in, room 12. So if I was in room 2 starting an IV, I would hear the physician say that and I would know, hey, I'm taking care of room 12. As soon as I get this IV, I'm going to go check and see what that stat med was. With health information technology, what's happened is the physicians are putting in or providers are putting in orders. They're no longer saying out loud, I've got a stat medication order. So when I'm sitting at the bedside doing the IV, I'm thinking in my head, okay, in room 2, I'm going to finish this IV and I'm going to put the blood, send the blood down to the lab, and then I've got to go to room 4 because I know they've got a medication order. I don't know there's a new medication order unless I stop and look at the computer. And when you're very busy, you don't always stop and look at the computer to see you've got a new notification. So the other side of health information technology, for all that it's good for, we can't remove that human factor, and we've still got to talk to each other, and we've still got to we still need to promote face-to-face communication and verbal communication in addition to the health information system. It's augmenting what we do. It's not replacing communication. Um, remember, communication is behavioral too. So think about any time you were on a call. Think about me right now discussing, lecturing to you guys. I can't see your faces. I can't see your reactions. I don't know if I'm talking too fast, too slow, um, if I'm confusing you, if it's making sense, if you're falling asleep and tired of hearing what I'm saying. So behavioral expectations, cues within the group. Um, that all needs to be considered when you're designing these systems, and think about how it works within the norms, um, uh, of people, and how they're going to use it, how it's going to work within your organization you're designing it for. That it does alter those forms of communication, sometimes for the better. Now we can automatically page respiratory therapy when there's an EKG or when there's a stat nebulizer. Their beeper will go off, where before you'd have to have somebody stop what they were doing to actually place a phone call or manually page them. So it can help, but also remember where the limitations are. And maybe you still have some disparate systems. So even though it works really good to page respiratory therapy for an EKG or a stat nebulizer from the ER, it may not page respiratory therapy for a stat treatment, say from the NICU or the ICU. Maybe there's a disparate system there. And so not everything is all working, and where those limitations are. Different communications tools, just like we talked about, technology was a pair of scissors, two levers. We've got different communication tools and how those are going to translate into an electronic world. What a whiteboard, which looks like a spreadsheet, a lot of times are now looking like electronic spreadsheets. Clipboards, what did that mean in a paper-based world, and how does that translate to electronic? What does a dashboard or clinical summary look like, and how can we make it interactive and dimensional now that it's electronic? Handoff notes. We talked about SBAR, so how do we transform that into an electronic format so that it still makes sense and follows workflow? Multidisciplinary round tools. So just like we're talking about care coordination is the coordination of care across different disciplines. A discipline is physical therapy, a discipline is occupational therapy, a discipline is nursing, a discipline is social work. So when we talk about taking care of these patients in a setting where it's multidisciplinary and they're rounds, again, it's communication tools, tracking forms, progress notes, dashboards, so that if I'm a physical therapist coming to take care of the patient and take them on a walk, and they've had a knee replacement or knee surgery, I should be able at a glance to know, did they get their pain medication yet? Depending on the type of pain medication, if it was an oral pain med or an IV pain med, did they give it at a time that's sufficient for it to act? So an IV med usually takes about 15 minutes to start to relieve pain. An oral med can take up to an hour. So it's that type of multidisciplinary rounds and tools and care coordination, so that if my patient, in a dashboard, if I can see they gave an oral med 10 minutes ago, maybe I can go take care of one of my other patients and walk them and come back to this patient in an hour when it's had time for the medication to work, because then they're more likely to walk comfortably and get better therapy, if that makes sense. Um, so how are these multidisciplinary tools being used so that anybody that's taking care of a patient can interact with the patient, know what's going on with them, and provide them the best care at the best time, um, in the most efficient manner, and keep them at the center? We've got rounding lists, sign out tools, daily goal forms. There's all kinds of process oriented tools as well. So patient centric tools, remember the patient's at the center, and then process oriented tools. These are the things that are going to help um, keep track of what's going on with the patient, so we can see variances. And then we've got decision support tools. You'll hear the term clinical decision support, or D as in dog, S as in Sam, clinical decision support tools. Those types of tools are to help us make decisions. So remember, um, we we sort of talked about the antibiotic. There's tools in the background that will say if a person has an infection from um, a urinary tract infection versus an ear infection, there's different antibiotics. So the suggestion can be part of the alerting system or clinical decision support system, can let the physician know which antibiotic may be best, not telling them what to do, providing them some support tools so they can make the best decision on how to care for the patient. Graphically displaying blood pressures or temperatures. You can easily see at a glance that the temperature is going up or their temperature is going down, or their blood pressure is going up or their blood pressure is going down. It's not about the specific number. You don't need to know at a glance. At a glance. If I walk in and I'm worried about you, I want to know if your headache that you're complaining about, I'm going to look really quickly and see a graph that your blood pressure is going really high, that it's going up. Really doesn't matter at that very instant. It doesn't matter if your blood pressure went from 100 to 300 systolic and you're stroking. What matters is it's gone up. Then I can drill down to the details. If you say you have a headache and I glance over and your blood pressure graph is linear, it's stable, it's not fluctuated, then I can start making an informed decision about something else to look at, bright lights or some other cause of your pain, um, the reason for your headache, if that makes sense. So in summary, we've got quality is a set of structures, processes that equal a desired outcome. Improvement has to do with those 6 aims of the Institutes of Medicine and their national agenda, the efficiency, equitable, timeliness. That all equals quality, which remember is the type of care everyone deserves. Everyone deserves quality care. Meaningful Use had these 5 goals, which are very similar to the 6 aims. HIT can have unintended consequences. Even the best designed systems can have issues or flaws that lead to workarounds. There's 2 types of errors. There's system errors and person errors. And health information technology is changing communication, not replacing it. We're augmenting it, not replacing it. People still need to have effective communication. A message sent and the same message received is the message that is sent.